Hello, I'm Carol Danaher, Public Health Nutritionist and Director of Childhood Feeding Collaborative for the Public Health Department of Santa Clara County. This has been seen live at various venues throughout Santa Clara County by more than 200 pediatric primary care providers. I have no relevant financial relationship with the provider of any commercial services or products discussed in this CME activity. Today's topic is childhood obesity prevention, and we're going to focus on the feeding practices that contribute to the development of obesity in early childhood. Childhood Feeding Collaborative is funded and supported by numerous organizations, and I just wanted to recognize those organizations here. This is today's agenda, and I'm going to start by describing to you the Childhood Feeding Collaborative's obesity prevention activities in the county. I'll also tell you about 2 new referral resources that you can use for your clients. Childhood Feeding Collaborative focuses on the known and evidence-based parenting risk factors for obesity. We also rely on a best practice feeding model. Early intervention is crucial for the prevention of obesity. I will be asking you to begin your intervention as early as the 4 to 6 months of age when solid foods are first introduced. Our strategy is to help you, the primary care provider, learn how to recognize the normal feeding challenges of early childhood so that you can help the parent correct their feeding strategies early before health issues result. We consider you, the primary care provider, the starting point for best practice feeding guidance. Surveys in the literature and also our own local surveys show that parents rely on you first and foremost for feeding and nutrition information. Childhood Feeding Collaborative has then engaged all of the reliable feeding, nutrition, and parenting touchpoints in the county so that as families navigate through multiple systems, they are going to hear the same best practice feeding guidance. We provide a parenting class to families that's called the 5 Keys to Raising a Healthy and Happy Eater. You'll hear more about that referral resource. And families in this 2-hour class hear about parenting practices and feeding. Our treatment program in the county for obesity, the Pediatric Healthy Lifestyle Center, also provides best practice feeding guidance that will support the guidance that you give. Managed care plans offer health education to their members, and their health education classes also include feeding guidance to parents. The WIC program has expertise. Every single one, nearly all of their nutrition staff has been trained extensively in best practice feeding. And this is particularly important because 60% of the infants in Santa Clara County will enter the WIC program sometime during their first year of life. We have trained feeding experts within mental health, within the specialty nutrition clinic, Black infant health, adolescent family health program, public health nursing. All of these referral resources can support you when you give best practice feeding guidance. We also are partnering with child care programs so children in child care are fed in environments consistent with best practices. The Pediatric Healthy Lifestyle Center is the first referral resource I want to talk to you about, and it is our county's treatment program for child obesity. They use a lifestyle approach. There are no diets ever given with this program. And their guidance is consistent with the best practice feeding model that you will learn today. The center is located at the various Valley Health Center pediatric clinics throughout the county. These are your referral criteria to the Pediatric Healthy Lifestyle Center. Refer children who are overweight and obese, or children with comorbidities, whether or not they are overweight or obese. I want to remind you that children with consistent growth above the 85th percentile are most likely growing normally and should not be classified as overweight. For very young children, the Pediatric Healthy Lifestyle Centers offers early intervention for high-risk children. Our second referral resource available to you is the 5 Keys to Raising a Healthy, Happy Eater class. And this is a parenting class. It's 2 hours long. It's offered in English, Spanish, and Vietnamese. And this is a fabulous resource for you. We've done 3 years of outcomes research on it, and at follow-up, between 85 and 88% of the parents make 1 or more changes in behavior, and 90% of those parents feel successful with the behavior. It's a class that teaches the parenting model, the best practice feeding model. And it's taught in a learner-centered format so that parents get their individual questions answered in really quite some depth. And I want to stress at this point that there is no threshold for entry into this class. We don't care what the health plan is. We don't care whether the family even has insurance. We do ask that families have children under the age of 6 because that's where what the class is geared towards. All of these referral resources, both for Pediatric Healthy Lifestyle Center and 5 Keys, are in the attachments that are associated with this presentation. So why do parents attend the 5 Keys class? Here are some of the most common reasons families come to the 5 Keys class. And if you look at each of these, you'll find that they have a common solution. And that solution is parenting. This is a quote given to us by a parent who attended the 5 Keys class during our follow-up survey with them. And I include it just to show you how important you are as the provider of nutrition information. When parents hear guidance that's different from what you give, it is very confusing for them. Now I'm going to tell you a true story. This slide represents the daily intake of a 2-year-old, half gallon of milk a day, candy, and ice cream. The child was seen by her primary care pediatrician at the Valley Health Centers. And during that exam, this child was found to be so severely anemic that the physician sent them, the mother and child, immediately to the emergency room for possible blood transfusion. Now, this mother knew what the child needed to eat. She had tried to get the child to eat fruits and vegetables and a wider variety of protein foods, and it was tough. You know, this child would tantrum, refuse to eat other foods, and so the mom wanted to make sure she was fed, and this is what she gave the child. The emergency room doctor who saw this family had fortunately just attended this very same training at one of the pediatric grand rounds. He recognized the cause of the anemia as the parent's inability to initiate that very first transition in feeding, that from a milk-based diet to solid foods. He then made the referral for this parent to the 5 Keys class, and she attended one of our Vietnamese language classes. We followed up with the mom about 8 months after she attended the class, and she reported that the child was eating a wide variety of foods and that the problem had been solved. Now, ideally, I would have liked this primary care provider to have referred the child when she was maybe 9 months old, when the parent first reported difficulty with picky eating for the child. And then we could have prevented not only the anemia, but also hopefully the obesity as well. Let's move on now, and I will tell you about your best practice feeding model, the division of responsibility in feeding. The division of responsibility was created more than 30 years ago through the pioneering work of Ellen Satter. It has been tested through numerous peer-reviewed journals, research articles, mostly that are cross-sectional. Now, what's most important for you to know is that the division of responsibility focuses on parenting, and it shifts the focus for change to those parenting practices rather than on fixing the child. And what I mean by fixing the child is when you, the pediatrician, tell a parent, you have got to get your child to eat more fruits and vegetables, or you cannot let your child eat so much, you're telling the parent your child is flawed, fix him. And this is not a strategy that is effective. Parents can't implement and sustain this over the long term. So especially in early childhood, it's the parenting practices that receive the focus. The division of responsibility is considered your best practice feeding model by yours and numerous other policymaking organizations. Also, each of your expert committee reports on obesity consider division of responsibility the best parenting style to prevent obesity. Let's talk first about the division of responsibility in infancy. It's a little different than that during childhood. The parent is responsible for what the infant is fed. It's either breast milk or formula. And the infant takes responsibility for every other aspect of feeding. How much she feeds, how frequently, how fast, how slow. Now, the only way that the infant can hold on to that responsibility is if the parent allows the infant to have it. And to do this, the parent must observe the infant's cues and then take the lead from the infant. And it's this attentiveness to the infant cues that sets the parent up for success during all of the feeding transitions that occur in early childhood. One of the important realizations that came out of Satter's work was that feeding is truly a relationship between parent and child. And in this relationship, parents have unique responsibilities and children have unique responsibilities. As I talk about the division of responsibility in childhood, I'd like you to think back to a mealtime that you shared with a young child and use that as the context with which to learn about the division of responsibility. In the division of responsibility in childhood, the parent is responsible for all of the structural items around feeding: what's served, when eating is allowed, and where eating is allowed. The child takes autonomy or responsibility over how much they eat and whether or not they eat what is provided. Most feeding problems in early childhood, in fact, I would almost say all, result when the division of responsibility is broken. Parents either handing over their responsibilities to the child or denying the child autonomy over their responsibilities. Now let's go now and talk about each of these keys in depth. And I do want to make a reference to the fact that we have renamed the division of responsibility the 5 keys based on these 5 separate domains. Key number 1, what food is served. Now, most parents recognize that this is their responsibility. However, it's one of the keys that parents most commonly hand over to the child. Children do need to learn to eat the foods that the family eats. That's pretty much the bottom line. In doing that, parents should, as early as possible, offer the child modified table foods. I recommend as early as 8 months of age. Is not too early to begin doing that. The jarred baby foods do little to help the child experience and learn to like the foods that the family eats. So what does it look like when a parent hands over this responsibility to the child? We've all seen children who are, for example, the pasta lovers and really don't want to eat anything else. Parents who then stop serving other foods and only serve pasta every meal, so to make sure that the child eats enough, that parent has handed away his responsibility to the child. Another example, I recently spoke at a child care program in Palo Alto, and after my talk on the division of responsibility, a dad raised his hand and he said, "My 3-year-old will eat nothing but a really chocolatey, sugary breakfast cereal for breakfast. What do I do?" So I asked the dad, "Well, what's your problem with that?" And I asked that question because I wanted to find out if he had indeed handed over his responsibility to the child. And his answer indicated, of course, he had, and that he said he would much rather she have something whole grain, lower sugar. He named a few breakfast cereals. So what happened is that this child certainly preferred the chocolatey cereal, but what the dad did was that he gave up on her ability to learn to like the foods that the family eats. That dad is responsible for what food comes into the house. There is no reason that he needs to serve the child a separate food that he does not agree with or that the family doesn't eat. Children do far better when they know that they'll be fed. So parents do need to provide scheduled meals, and also in early childhood, scheduled 1 to 3 snacks a day. And then no eating in between those. Water's okay, of course, but a child who is allowed to graze all day long is a child who has been given the responsibility of when to eat. What I mean by taking the lead is that the parent makes decisions on when eating occurs, and they don't ask the child. For example, parents may ask a child, are you hungry? Do you want breakfast? Instead, the parent says, breakfast is served. The parent assures that every meal is offered on a routine basis. Parents are responsible for where eating is allowed. And I would say as early as possible, beginning at least by 8 months of age, children should be included at the family table. This is important because the parents are role model. Children learn. They see their parents eating the food that they're being offered, and they also learn how to behave when they sit at the table with the parents. We also recommend that the TV is turned off during mealtime. One of the reasons for this is what the research shows is that children eat more when they eat in front of the TV. Some parents use this as a strategy to get their child to eat more, but it's not a wise strategy. After attending our 5 Keys class, one of the most common behavior changes is that parents do turn the TV off while they eat. Now, we serve a lot of low-income families in Santa Clara County, and they may not have a dinner table. Multiple families or family members may share a small apartment. So we've had families who identify their family table as the bed in their bedroom, which is their space. They turn the TV off, and that's just fine. The division of responsibility is a package deal. Parents need to hold on to the structure around feeding in order for children to succeed with taking autonomy over how much they eat and whether or not they eat what's served. By allowing children autonomy over these 2 important behaviors, the child's ability to self-regulate their intake remains intact. Children are born with very intuitive mechanisms for satiety control and energy intake, and the division of responsibility supports that. Normal eating behavior for a child is that they may eat vastly different amounts meal to meal and day to day. Parents need to understand what is normal eating behavior. I consider mealtime behaviors the glue that holds the division of responsibility together. It is the parent's responsibility to teach the child in a developmentally appropriate way how to behave at the table. Children who learn how to behave at the table will have parents who are more willing to eat with them, and family mealtime will go far more successfully. Now, children also need to be taught how to politely refuse food so that they can hold on to their responsibilities of whether or not to eat something. I'd like to illustrate to you how we applied the division of responsibility to a family that attended the 5 Keys class. This mom was doing a really good job of providing structure around mealtime. She had a preschooler, and when she came to the class, she also had a 2-year-old. When this younger child turned 2, her behavior changed dramatically. She no longer wanted to sit at the table with the family, and she would take a bite, race away, go play, come back, take another bite. And when the mom tried to plop her in her chair and make her stay there, the child would tantrum. In the problem-solving style that I mentioned earlier, whereas when a parent presents a problem, you want to trace it to where the division of responsibility has been broken. And in this case, it was the where that became problematic. So the solution was a lengthy discussion with full of open-ended questions, but I'll give you the very short version. The mom had to identify a way to take back control of where eating was allowed. And basically what she needed to do was to explain to the 2-year-old that they eat dinner at the table, and that if she wanted to leave the table, that was fine, but it meant that dinner was over. And it doesn't take very long before this child understands if she's going to eat, it has to be at the table. Now, before we recommend a major change in behavior like this, because this is pretty significant, we would want to make sure that the mom was regular about her meal times and planned snacks, so that for this parent, if she was always routinely serving a bedtime snack, she knows, she has the comfort of knowing that the child would not go all night without eating. And if it's given as a routine, then it's not perceived as a reward for not eating dinner. Those are disassociated. I'm going to show you a number of videos during this presentation, and this one I chose specifically because the parent is following a division of responsibility. It's just a great example to put together what we've just talked about.
At 6.5 months, Ella is an experienced eater of solid foods. She loves her cereal and eats it readily. Kathy gently keeps Ella's hands out of the way. Ella's touching the food distracts her and makes a mess, but allowing some touching lets Ella learn.
Your hand down. There you go.
Notice Ella's closing her lips over the spoon and her good control of her tongue.
Hi, I'm right here. Look at me.
Kathy reminds Ella to pay attention. Ella wants to see what's going on, but her mother isn't going to do her eating jobs for her. Ella is keeping most of the cereal in her mouth, even though some ends up on her chin.
This is avocado.
Ella had avocado once before and refused it after a single bite. This time she's willing to eat more, but does she like it or not? Even though she makes a face, she's willing. Once they get used to it, children often really like avocado. Back to a few bites of baby cereal to clear the palate. You can tell that Ella is more enthusiastic about this than she was the avocado.
Good job. Here, let's have some more. Hey, Ella.
Again, Kathy gets Ella's attention. The meal is enjoyable for both Ella and her mother. Ella's interested in eating because her mother treats her in this sensitive and responsive fashion. Ella is learning that the world is a friendly place where she is loved and respected.
I got one more thing for you to try today.
Now what?
These are carrots, Ella. Carrots.
Is she going to like the carrots? Yes, these are good. Let's have more of those carrots.
How do you like them?
Yes, indeed. She likes them pretty well. Ella has her own way of savoring her carrots. Now back to the cereal.
You like that? Are we done? Are we done? Everything's coming out.
Is Ella getting done? Kathy comments that the food is coming back out on her chin. Kathy could stop here, or not. Ella isn't going to eat any more than she needs. She likes having the food in her mouth, and she knows how to get rid of it. Another child would show she's had enough by not opening her mouth or by turning away from the spoon. Ella's mother calls a halt and cleans her up.
Are we done?
Then they see if Ella wants to top things off with a little breast milk. Ella's not interested. She's full, and typical of the 6-month-old, she wants to see what's going on. Kathy's finding out that they could skip this breastfeeding and Ella wouldn't miss it. Instead, she could have a little cup of breast milk or formula at the meal.
I want to end this segment of the presentation by giving you a sports analogy. When families come to our 5 Keys class, one of the first things we do is we ask them to tell us about a skill that they have taught their children. Talk with parents about their ability to teach their child. They all have this skill. And we then say that eating is also a learned skill, and they can apply this ability and the skill that they have to teaching their child how to become a good and a healthy eater. This is a 3-year-old Jasper, 3.5-year-old Jasper, and I had the very good fortune of watching his dad teach him how to hit a ball with a bat for the very first time. And you can see by looking at Jasper that his dad has picked the developmentally right equipment for him. He has a big, lightweight plastic bat, and the ball that the dad threw was a wiffle ball and pretty big too. And then he taught Jasper the developmentally appropriate rules for the game. In this case, it was 2 simple rules: how to stand relative to the pitcher and how to hold the bat. And you can see Jasper's pretty good at following those rules. And so the dad, pitched the ball the first few times, and we all know what happened. Jasper missed the ball, of course. And I think it was about the 8th or 9th time that Jasper was finally able to connect with that ball. And this is exactly what a parent would expect and what you would expect too as I tell this story. What was most wonderful about this interaction was watching the dad. And the dad was patient with Jasper. When Jasper missed, it was no big deal. When Jasper finally hit the ball, it was no big deal either. Throughout this process, this patient, repetitive process, the dad had what we call mastery expectation. And that is that everything about the dad, his mannerisms, his tone of voice, showed that he trusted and knew that Jasper would master this skill. There was absolutely no doubt when you watch that dad's behaviors. So mastery expectation was an important part of the interaction. And in fact, after I took the camera shot, Jasper came up to me and he said, "I don't hit the ball very well yet, but I will pretty soon." And so Jasper also internalized that father's mastery expectation. So let's contrast how parents teach their child, say a sport, with how they view their teaching role with feeding. What we know from the research is about 25% of the parents give up offering a new food after a child has refused it twice. And this is in our experience with the 5 Keys class as well. When a child, will use broccoli for example, refuses to eat broccoli twice, the parent too often says, "Oh, he doesn't like broccoli, we're not serving that anymore. Don't worry, honey, you don't need to eat the broccoli," or "Don't give him broccoli, he doesn't like it." And it's the picky child, the child who does dislike food for the first many times he tries it, that needs more than any other child the confidence, the mastery expectation from the parent that he'll learn to like that food someday, maybe just not right now. Now, another example has to do with mealtime behaviors. Parents come into the 5 Keys class and report the most extraordinarily disruptive behaviors at mealtime that they really don't know how to manage. And if you think about a sport, that no child would really be allowed to continue playing a sport unless he followed the rules. Well, with mealtime, children also need the patience, the persistence of the parent to teach developmentally appropriate behaviors. And this is what will ensure a very successful mealtime. Parents like the sports analogy. They see the connection that eating is a learned skill that they need to teach their families. Let's move ahead now and talk about the research on child feeding practices. This is a study in which parenting practices were assessed and related to child obesity in first grade. Now, in 1983, Maccabee and Martin defined 4 different parenting styles, from a very controlling style on the one extreme where parents give the child very little autonomy. The next would be authoritative, and this is the style that the Division of Responsibility teaches, where parents provide structure and give the child developmentally appropriate amount of autonomy. And then permissive and neglectful styles, where the child is given more and more inappropriate levels of autonomy. What Ree did was she looked at, in more than 800 children, these are all white children, she looked at the parenting style and the presence of obesity in first grade. And she found that children who had controlling parents had 5 times the risk of obesity as those with authoritative parents. There was no significant difference between the controlling parents and the permissive and neglectful parents. And this is supported in other research as well. There are some studies that look at parenting style with Hispanic children, and we find similar but not identical results, and certainly more research is needed in that area. The next 2 slides are from the Feeding Infants and Toddlers study from 2004. Now, this is a national random sample of more than 3,000 infants and toddlers between the ages of 4 months and 2 years of age. In this slide, it shows you the percentage of caregivers who view their child as a picky eater. And that first bar that you see, those are the 4 to 6 month olds. 19% of the caregivers view their 4 to 6 month old as a picky eater, which is surprising given they're really not eating much at this phase. And the rate of picky eating increases until about 50% of the 1.5 to 2-year-olds are perceived as picky eaters. This doesn't worry me at all. Children are picky eaters. It's a very normal phenomenon. But what does concern me is once a parent identifies and labels their child as a picky eater, what happens to the parenting? Does the parent become more controlling and force food onto the child? Or do they become more permissive and start short order cooking and really giving up on giving their child the appropriate opportunities? This graph shows the number of times a caregiver will offer a child a new food before deciding that he doesn't like it. If you look at the first two bars, those yellow and orange bars, those are parents who make the decision that their child dislikes a new food after they've tried it once or twice. This is 25% of the parents who decide that early. Depending on the age, between 1 and 10% of the parents give their child an adequate number of opportunities to try a new food before making that judgment. In this case, that was 10 different opportunities. In the research in general, that number of how many times does it take before a child learns to like a new food, that's between 9 and 20 times. So children need many opportunities, and parents are really giving up way too soon on them. This is a study by Aurel Valente et al., and they actually went into families' homes and observed 142 different families at mealtime. And what they found was that 85% of the parents encouraged their child to eat more than the child wanted, and that the lower SES quintiles had less structure around feeding, fewer meal times, and also the TV was on more frequently as well. There's been a fair amount of research on what does it take to get a child to learn to like new fruits and vegetables. And this is one of the classic studies by Fisher et al. In 2002. She looked at mother and daughter pairs. And what she found was that mothers who were role models, actually ate fruits and vegetables themselves, had daughters who were more likely to eat the new fruit or vegetable. And also that controlling, pushy behavior was negatively associated with a child learning to like a new fruit or vegetable. Now, this is a cross-sectional study, so we don't know the directionality of these findings. The other research in this area is also very similar to this in its outcomes. This is a study by Rolls et al., where they looked at how serving size influenced child intake. They had two sets of children. This is a sample size of 36 children. And they gave these children, 3.5-year-olds and 5-year-olds, macaroni and cheese in an identical bowl over a 3-week period. And they changed the amount of macaroni and cheese in that bowl, sometimes a small serving, sometimes medium, and sometimes large. And what they found with the 3.5-year-olds is that they didn't change how much they ate, no matter what the serving size was. They held steady. The 5-year-olds, however, ate more as the serving size increased. I find this study relevant to our population, our county, in that I hear from providers and from parents in the 5 Keys class that they have unrealistic expectations of how much their child should eat, and so perhaps are serving larger portion sizes to their children. We're going to move ahead now and talk about how to apply what you've learned to the Well Child exam. We'll start with the older baby, where your anticipatory guidance will focus on the introduction of solid foods. Feeding is a developmentally based skill. So from the timing of the introduction of solids, which should be based on developmental readiness, to how the parent feeds, is all based on child readiness and cues. Now, the infant at this age is mostly in the attachment phase, where they're learning to fall in love with their parents. They're beginning to identify themselves as separate and individual. And what this often looks like in feeding is that the child might try to grab a spoon away from the parent or push the spoon away. That's an indication they're ready to feed themselves. The parent's core task continues to be to notice these cues and react to them positively and change their strategies to meet the infant cues. Here are a few questions that you can ask during the Well Child exam to assess whether the parent understands the child's satiety cues, understands normal child feeding, and is feeding with the appropriate amount of structure and autonomy for the child.
Micah, 4.5 months, is getting his first introduction to solid food.
What do you think?
He likes it.
That's a big
He sees the spoon coming and opens his mouth when Jennifer touches his lip with it. Keeping it slow gives him time to react. Micah's not quite ready to start solids. He needs a lot of support to sit up. His head is unsteady. He may or may not be able to close his lip over the spoon and swallow, and most of the cereal comes back out on his chin. But it's okay to offer Micah solid foods. He's interested, he and his parents enjoy it, and his parents stop at his first sign of not wanting to eat. Babies develop differently even when they're twins. Micah's brother Sam is skeptical of solid foods. Nathan is respectful and engaging with feeding, and his tempo is no more rapid than Jennifer's. Sam's sitting and mouth skills are about the same as Micah's, but Sam's attitude is entirely different. He's not interested.
What's in your mouth?
His parents wisely pay attention to his reaction and stop trying to feed him. Respecting Sam's wishes now will make him more likely to accept solid foods later on. However Micah and Sam feel about starting solid foods, being part of this cheerful family meal shows them what eating is all about. This is, of course, not recommended practice for using these seats. Ordinarily, Micah and Sam sit in the middle of the table, and their parents keep a close eye on them to be sure they can't kick or wiggle themselves around.
Introducing solid foods to an infant is a very challenging job for parents, and there are many missteps that can occur. I've listed some of these, and in each of these, the parent has either taken over responsibility away from the child or has handed over their own responsibilities to the child. And in each of these cases, parents who complain of any behaviors related to this, the child and the family needs to be referred to the 5 Keys class, and we can help them improve their strategies with parenting. For parents with the older baby, these are some of the common reasons that providers refer children to the 5 Keys class. Now, I want to talk specifically about the use of Pediassure. Pediassure is heavily marketed to parents. For WIC participants, the pediatrician must prescribe Pediassure for the family to receive it as part of the food package. Pediassure has a reputation among WIC parents as providing all those extra nutrients and calories that parents feel their child isn't getting from eating solid foods. What I would like you to have learned from this presentation is that when a parent asks you to prescribe Pediassure, that you will first question what is the parenting issue going on that has created this perception for a need for Pediassure. And this is a time to first refer the family to the 5 Keys class. In most cases, it's the parenting expectations and the parenting behaviors that need to be improved, not to give the child Pediassure. I work with dietitians, registered dietitians, and WIC nutritionists. They all feel that Pediassure undermines a child's ability to learn to like new foods and also will undermine, because of that, the family meal time. We'll now move ahead to the 9 to 18-month well child exam. We're now going to talk about the almost toddler, and the focus of your anticipatory guidance should be to help the family move towards including the child at the family mealtime. Developmentally, the almost toddler is really focused on being independent and doing things for himself. The parent's core task at this age is to provide table foods that are safe and easy to pick up for the child so they can learn the skills of self-feeding, to provide ample opportunity to learn to like those foods, and of course to include the child at the family mealtime.
These year-old twins are eating most of what their parents eat and feeding themselves with their hands. Madison is hungry and ready to eat, and so is her brother Daniel. Pam and Alan have adjusted their mealtime so they can enjoy eating with their children. Alan picked up a pizza on the way home from work. Pizza is soft and easy to chew. He and Pam have cut it into small enough pieces so the children can feed themselves. Maddie gags a little. She can breathe, so she isn't choking. She accepts a little back patting from her mother, but she can work that bit of food off the back of her tongue by herself. Daniel has good hand and mouth control and so enjoys feeding himself that he eats almost anything. Even though he's chubby, Daniel must be allowed to eat as much as he is hungry for. Studies show that trying to get children to eat less makes them eat more when they get the chance. In the long run, restricting Daniel will make him fatter, not thinner. Alan ignores his telephone. Even the ringing distracts Maddie. Telephones, texting, and television take away from family meals. Children know they're being ignored, and they don't do as well. Maddie puts food in her mouth, samples it for taste and texture, then spits it back out again. This is typical eating behavior, but Maddie isn't finished with the food in her lap and goes after it. This time, she chews it up and swallows it.
Watermelon, Daniel. He's revisiting the cucumber.
In goes the strawberry. Out it comes, back in. Notice her mouth action.
Whatever you want. Don't have to eat in any order.
Do you want a knife for your pizza, or are you good?
I'm fine, thanks.
Now for some watermelon. Maddie can bite off and seems to use her whole face to eat. She uses her tongue to push the food between her jaws. Maddie is right on the verge of learning to chew. Daniel is still eating enthusiastically. He's tuning in to his hunger and fullness and eating as much as he needs. His parents maintaining a division of responsibility in feeding will let Daniel grow up to have the body that's right for him. Maddie drinks from an open cup, which lets her mouth develop. Now that the children eat and drink so much at mealtime, they won't miss their mealtime bottles and don't need them. After a while, they can still have formula in a bottle or a cup as a bedtime snack. Maddie is good at this and would dearly love to do it all by herself. She'll be able to do that surprisingly soon. For the next few weeks, her mother's wise to give her some help.
Just wants milk.
Can we wipe up real
If
quick?
Pam could stand it, it would be better to skip this wiping up. Trying to keep Maddie clean during the meal is hopeless anyway, and Maddie's impatient with it. Is that why she knocks her plate onto the floor? Daniel's lost his plate as well. At this stage, using a plate isn't necessary. Daniel cares deeply about feeding himself, even though it's a struggle for him to do it.
This approach might work better than actually cutting it up, because it'll take
Not letting him feed himself could cause feeding problems. Eventually, Daniel loses interest, stops on his own, and the meal is over.
At the 9 to 12 month well child exam, children are still taking breast milk or formula. The most important role for feeding is to have a positive experience and to expose the child to an increasing variety of foods and to include the child at the family table. How much they eat is not really so important. They still have that breast or bottle. Parents often worry that their children don't eat enough. This handout provides a useful starting point. It explains that children may eat more than this amount or not even as much as this amount, and not to worry about that. This handout is in 3 languages and is available with the handouts associated with this presentation. And also you can contact me at Childhood Feeding Collaborative, and we will supply you with all that you need. Here is the same list of parents' concerns that should initiate a referral to the 5 Keys class. I want to focus now on growth divergence. Normal growth is consistent growth, and this is a child who's growing quite consistently and normally along the 25th percentile. Now, your practice guidelines define failure to thrive as occurring at the 3rd percentile. This child diverges downward to the 10th percentile, and this is the time to refer the family to the 5 Keys class. The child is still considered to have normal weight, but behavior change takes a long time for families to achieve. When the division of responsibility is newly established, feeding often becomes worse before it gets better. So again, early referral at the first sign of growth divergence downward. If the growth continues to diverge, that's the time to send to the pediatric nutrition specialty clinic or to the registered dietitian that you work with. Likewise, when growth diverges upwards, often there is a parenting correction that can be made. So this child, when it diverges upwards to the 50th percentile, refer the family to the 5 Keys class. If growth continues to diverge upward, that should initiate a referral to the Pediatric Healthy Lifestyle Center. Don't wait for a child to pass any more percentile lines in order to get to that cutoff value of the 85th percentile or 95th percentile. Now we're going to talk about the toddler, and the parent's core task here is to hold on with all of their might to the division of responsibility and to give the child the amount of autonomy that is developmentally appropriate. At the 15 to 18 months well-child exams, you'll be dealing with a toddler whose core developmental task is to experience themselves as separate from their parents. The parent's core task is to hold on to the division of responsibility, provide those family meals, and insist on teaching mealtime behaviors so that the mealtime is not undermined. Also to give the child, again, plenty of opportunities to learn to like new foods.
Overlook what you can and address only what you have to would be helpful advice for these committed and anxious parents. Gage starts out by eating his bread. His parents laugh at him and he mugs a bit, but he takes care of business. Once they help Gage get served, it would be wise for Amy and Glenn to talk with each other and let Gage attend to his eating.
Try some of your noodles, Gage.
Before long, Gage's parents start with the directives. They seem committed to his eating noodles. What one says, the other repeats, and repeats again. A single reminder might be okay, but saying it over and over amounts to pressure, and pressure makes children eat less well, not better.
Do you want some
Bribing
Jell-O?
with dessert is more
Eat a
pressure,
noodle.
and that doesn't work
Eat some of your
either.
noodles and you can have some Jell-O.
Amy and Glenn come at Gage from both directions.
No, it's cool now.
I think it's cool.
They chime in with each other, trying to persuade Gage that the noodles aren't hot.
Not hot anymore.
What does it taste like? Is it good?
Gage is showing the pressure.
Did you taste it?
Stop it, Gage says. Don't. His parents need to deal with him one at a time.
Gage, look. Can you stick your finger in that noodle?
Now for some distraction. Let's try making that noodle a toy. Gage plays along, but he knows this is just more pressure. Gage is holding up, but he's getting more and more upset. Glenn puts more food on his plate, and Gage distracts by asking for the tongs. Amy says no, but then she resorts to bribery.
If you eat a noodle, I'll let you play with them.
This last bit is too much for Gage. He can't take any more, and he throws a mild tantrum. You do have to tell toddlers no, and they do have tantrums, but it's important to avoid causing them. This time, Gage's tantrum grew out of all the interference from his parents. Instead of working so hard, Amy and Glenn can relax and enjoy eating and talking. They've done their jobs of providing the meal and eating with Gage. Now they can trust Gage to manage his own eating.
Parents who cross the lines of the division of responsibility with a toddler especially are really not going to be very successful. And it's best to keep that structure in place and to allow the child the autonomy that he needs. Research shows that when a child tastes a new food, they're more likely to learn to like it. And it's certainly time with a toddler to encourage him to taste foods. And this is how it's done. First, a child should be allowed to just look at a food and not taste it. Remember, we talked about it may take 9 to 20 times of just looking and being exposed to that food before a child feels ready to try it. Then a child can be asked to taste it, but not having to swallow the food. And when a parent suggests this to the child, they need to teach the child how to politely spit the food out. Often, though, the child realizes it's pretty good, and they'll swallow the food. And this is the time where the parent really has to control themselves and not encourage the child to take a second bite or remind them, see, I told you that you'd like it. Anything that the parent adds to this experience will only increase the danger threshold for trying a new food. In the 15 and 18-month well child exam, Bright Futures asks you to talk to parents about tantrum management. We do the same in the 5 Keys class because tantrums are one of the behaviors that undermines a parent's ability to have a family meal. This is the guidance that we provide families. We use a timeout and we let them know very clearly that anything that they do to avoid the tantrum or to put up with the tantrum will only make tantrums more frequent and worse. No parent likes it when a child tantrums. It's really very stressful. This quote was taken from one of the classic pediatric psychoanalysis texts and reinterpreted, and I think it says just beautifully that tantrums are indeed an opportunity for the parent to show the child that he is loved and to make the child feel secure, knowing that the parent can stand up to the tantrum. Let's move now to talking about the role of feeding practices and the development of obesity in early childhood. The child obesity epidemic is really relatively new. Most of the research on child obesity is done on school-age children, and much of it driven by eating disorders. There's just not a lot on the preschool-age child. In 2008, Nelly et al. In Obesity examined the efficacy of the division of responsibility in the prevention and treatment of child obesity. And what she found in the research is that there is consistent support for the model. The most consistent research showed that food restriction harmed children. This is a study by Anderson et al. Came out in Pediatrics in 2010. They assessed the presence of 3 family routines on the prevalence of obesity in preschoolers. They had a nationally representative sample of more than 8,500 preschoolers. The routines were family mealtime that was offered more than 5 times during the week, 10.5 hours or more of sleep during each weekday, and less than 2 hours of television each weekday. Children who had families with all 3 of these routines had a 40% lower prevalence of obesity than children who experienced none of these routines. Each of these routines significantly lowered prevalence of obesity, and the odds of obesity were reduced between 23 and 25% for each of these individually. There is a new body of research emerging on the role of eating competence and health. Eating competence is sometimes called mindful eating or intuitive eating. In this study, the authors found that obese, competent eaters were healthier along a number of parameters than obese adults who were not eating competent. And division of responsibility teaches a competent style of eating. I really look forward to more research in this area. It's really quite tantalizing. A randomized controlled trial of the division of responsibility was published in 2012 in the Journal of Developmental and Behavioral Pediatrics. The study assigned 62 families to either a division of responsibility-based intervention or a control intervention based on the National Institutes of Health We Can program. We Can promotes healthy eating and physical activity. Intervention and control groups attended 5 group sessions. The outcomes studied are parental pressure to eat and food restriction. These are well-chosen outcomes, as there is consistent evidence in the literature that both food restriction and pressure to eat increase a child's risk of obesity. The findings show that parents assigned to the division of responsibility intervention reduced their pressure on the child to eat, and for girls only, parents reduced food restriction. The control intervention increased these negative parenting behaviors. This study is significant as recommendations for child obesity prevention and intervention almost always include guidance to eat a certain amount of fruits and vegetables and other healthy food. In this study, these recommendations were detrimental to parenting practices. This study recommends division of responsibility as the basis for physicians' guidance to parents. This is a study by Rhee from 2008 where they assessed the relationship of parenting style, parenting behaviors, and family functioning and the development of obesity in childhood. And what they found was consistent evidence that food restriction harms children. Food-restricted children eat more. They eat more in both food and calories. Their BMI and weights are higher. The negative effect of restriction is greater on the obese child. And perhaps because the child is obese, parents restrict more commonly. In the experience of our Pediatric Healthy Lifestyle Center, the food-restricted child is far more difficult to treat. It takes a long time to undo the harm of a child who has been restricted. So for the overweight child, what's your option? If you're not going to encourage food restriction, what are you going to do? Your practice guidelines, the 2007 Expert Committee report in the Prevention Plus section, asks you to discourage food restriction and to encourage an authoritative style of parenting. This is a very obscure way of asking you to teach the division of responsibility in feeding. Your practice guidelines in that Expert Committee report go on to recommend that you advise parents to limit portion size and to encourage them to have their child eat at least 5 servings of fruits and vegetables a day. Now, the only way to make these guidelines consistent with the previous ones, where their parents should be parenting authoritatively, is to teach a division of responsibility. That is the context that will make your guidelines consistent, where parents offer a realistic serving size and let the child eat more or less than that amount. And by following a division of responsibility, research shows that children are more likely to learn to like vegetables and fruits. There's a growing body of research showing an association between infant birth weight and growth with childhood obesity. I'm going to talk to you about 3 of those studies. In Pediatrics in 2009, they found an association between high infant birth weight and obesity at age 3. In obesity in 2006, there was an association with rapid infant weight gain and obesity at age 4. And in the British Medical Journal, a review of the literature found that rapid infant weight gain is related to infant growth. They suggested in that article that feeding practices, parenting practices of overfeeding may in fact be part of the cause. What I want to emphasize with this research is that it finds associations, but there is no recommendations for food restriction in infancy. That would be a very harmful interpretation of these studies. What can be a useful take-home message is that parents need assistance and guidance on parenting well in these early years so that children maintain their ability to self-regulate their intake and are not overfed. You may have seen a family like this one, a 3-year-old boy, weight off the charts, and a mom who is really desperate for a strategy to help her child. They live in a small apartment with other extended family members, and someone's always eating. The mom has tried to prevent the child from eating with other family members, but he cries and he says he's hungry, and the dad is not supportive of the mom's efforts. So you're going to refer a child like this to the Pediatric Healthy Lifestyle Center, but you want to provide her with some guidance during that office exam. Where I would start with this family is to, in a very open-ended discussion, ask the mom and work with her to see if she can carve out structured meals and structured snacks for her family that is separate from all of these other eating occasions. And then to work with her in visualizing that and beginning the implementation. The Pediatric Healthy Lifestyle Center will do the bulk of the work, and including working with the tantrums and the crying that the child has when he's denied the opportunity to eat with others. But you do want to provide a consistent message and a helpful one before the mom gets referred. Let's move on now to the 2 through 5 year well child exams. For the preschooler, the core task is mastery over the skill of eating so that they can become a healthy and a happy eater.
Chris and Glenn would do anything for almost 5-year-old Gracie, but they've gotten the message about child overweight. They try to manage Gracie's weight by controlling portions, restricting fat and carbohydrates, and encouraging vegetables, fruit, and low-fat food.
Thank you, Gracie.
Okay.
Tell
I'm gonna eat the rice.
Gracie asks whether she can eat the rice. The rule used to be that Gracie couldn't have rice, but she put up such a fuss that they let her have it if she eats her other food first. Weeks later, she still worries about her rice.
Okay. I have to put it on my plate too.
For Gracie, eating this broiled chicken is a chore. She gets herself to do the chore by making it a game.
Beating you.
You beating me?
And my chicken will what?
Good. Good job. Now you can eat your vegetables. Don't drink so much of the milk, honey. Okay? You're gonna fill yourself up.
Mommy,
Huh?
you forgot me to give me bread.
You can have bread after you eat your vegetables, okay?
And my rice too.
Trying to do Gracie's part of the division of responsibility gives Chris lots of
I
rules.
don't like it on the bottom.
These rules teach Gracie to eat based on what her parents tell her. In the process, she loses touch with her own feelings of hunger and fullness. This time, Gracie goes along with the rules. Other times, she puts up such a fuss that it spoils mealtime. Gracie wants to please her parents, but leaving the table hungry and unsatisfied is more than she can manage.
Now we can eat the rice.
Finally, Gracie gets to eat her rice and bread. She might not even be hungry at this point, but she eats it anyway. Eating by the rules makes Gracie overeat sometimes and not get enough to eat other times. Being afraid of going hungry will make Gracie food preoccupied and prone to overeat. It would be better to let Gracie serve herself and eat as much as she wants of all the food on the menu. After eating more than usual for a few weeks, she'll eat as much as she needs.
I beat
You did beat me.
you.
Gracie's little body is just the way it needs to be, but all of these rules about her eating are likely to make her fatter than is right for her.
As children grow, the family mealtime becomes a really important time to connect as a family, and you want it to be a positive experience. The division of responsibility creates the environment that is very, very positive. According to Bright Futures, feeding is not a priority for your anticipatory guidance during the 2, 3, 4, and 5-year well child exam. Now, I strongly encourage you to keep asking your feeding questions and consider these years as important prevention opportunities and also an opportunity for early intervention for the child that's already overweight. The parents' core tasks are to develop mastery in the child by continuing to provide opportunities for growth for the child. Eating with the child continues to be very important, and that family mealtime should definitely be encouraged. These are some of the behaviors you'll want to assess. Is the family eating together, TV off, and really is the division of responsibility being followed. This should look like a familiar list at this point. My bet is that you have a family like this. Now, this is an unhealthy diet that needs improving. However, from the focus groups that have been conducted on WIC clientele, we know that parents resent an all-out assault on their food intake. And a parent whose eating is so unstructured and disordered is unlikely to be able to respond to a recommendation of start eating chicken, broccoli, and brown rice. It's too much. In the 5 Keys class, what we do is we start where the parent is at. And for this parent, where there is no structure, it's eating on the run, we would ask them to make one small step, which would be to start scheduling a family mealtime. And maybe that family mealtime is at the fast food restaurant. Maybe they bring food home and eat together. And it's possible that they can only manage that a few times in the week. But what's important here is that you will have started them on a path of providing structure for themselves and their family. And with time, they'll be more successful and eventually be able to improve the quality of their food as well. And sometimes that just happens naturally. We're almost done, and I have just a few closing remarks for you. The pressures that you may feel as a provider to follow the cutoff guidelines and often fix the child approach of your practice guidelines may put pressure on parents, and that pressure may result in ineffective and inconsistent strategies towards the child. I've saved this slide for last because hopefully it does not scare you at this point. When parents follow a division of responsibility, the child can have this level of autonomy. It supports their ability to become a competent eater and to self-regulate their intake. If you have questions following this presentation, I encourage you to contact me either by phone or email, and I want to remind you that all of the handouts are in the folder associated with this presentation. I thank you very much for your attention today.